On the energy from Dr. Woodward's presentation here. This is my home base, and just as a background, we are in a situation where OB, GYN, and radiology share alike. So we do a lot of OB in the hospital and in the labor and delivery areas, and the obstetricians have private clinics in 2 or 3 satellites out across the highway. So we all put it all together in the same PAC system so my residents can see anything that happens in the network, and we're all connected to 10 different area health education centers in the state of Arkansas, since we're the only game in the whole state. So we do have plenty of material. And for those of you who wonder what that is, it's not a spaceship, that's our VA hospital. We are asked to disclose anything that might be a conflict of interest, and I have nothing to disclose. And to start with, if you were scanning this 3rd trimester fetus, how could you in 30 to 45 minutes say, there's a single intrauterine gestation with the fetal back to the maternal right, it's in cephalic presentation, it's 33 weeks, and I see no abnormality. On the average, we do a complete OB examination in 30 to 45 minutes, maybe sometimes even less than that, depending on whether or not we detect any problems. So it's very important for you to have a protocol, a certain way of looking at this pregnancy that you can reproduce from month to month to month, so you will have a program in your mind. So if you have a sonographer that does the scanning for you, do not disturb your sonographer until she or he is finished scanning the whole fetus, because there are certain things that we need to document and document well. Now, I call this talk the 12 steps in obstetric diagnosis, because if you just look at all these items that I have listed on this page, you will be in compliance with any accreditation criteria that you will be asked to be in compliance with when you apply for accreditation in the future. And whether or not you want to accept it, accreditation is going to be here very soon. So every pregnancy in the 2nd and 3rd trimester should have at least one comprehensive OB evaluation. And if later on you want to limit it to the placenta, or whether or not the fetus is alive, or any on a more limited basis, you should have at least done one complete examination. So we will try to go through this within the next 45 minutes. Step 1, you have to look at the uterus as a whole. Specifically, you have to know presentation and lie. Now, why is this important? I could not overemphasize this, because unless you know what the orientation is, you don't know what's up, what's down, what's right or left, you could make a mistake in diagnosis if you are not oriented. So given that the fetus keeps moving the whole time you're scanning, you have to keep reorienting yourself always. So scan, look where the head is, what happened to the legs, where did they go, did the baby flip, is the right side to the maternal right now, or what? It's always a constant reorientation. So note that we don't say vertex or brow or whatever presentation, we just say cephalic, the head's down. So if the head is down presenting, you can see the cervix, which is nice and long here, full maternal bladder. So of course the rump is in the fundus, so this baby is in a longitudinal lie. If the baby is in breech presentation, the head is in the fundus, and either it's a frank breech, a footling breech, a partial breech, you will see that the presenting part is not the head. So you more or less know what's up and what's down. Next thing, find a transverse view, either of the abdomen or the chest. And what you want to know is, where's the spine? Find the spine. Because once you find the spine, you relate it to what's presenting, then you will have an idea of where right or left is. And I can see my residents doing their body English when they scan, because they have to always imitate which way the baby is lying to determine what is right and what is left. So this is the abdomen, this is the spine. If the fetus is in cephalic presentation, then this is left and this is right, so that's correct. This is the chest, this is the heart axis over here, the spine is over here, so again, the baby's head is down, so this orientation is correct. And as you go to the base of the heart, you see the main pulmonary artery come across, and this is the aorta after it has crossed over. So this is normal, because this is the right and this is the left. Now in a breech presentation, obviously, it flips around, because then here's the spine, this is the left, and this is the right, because the head is away from you. And this takes a little doing, but once you get into the habit of checking your orientation all the time, then this becomes routine. It goes without saying that when you scan, you have to know how to hold a transducer. And I don't mean to be facetious when I'm doing that, but when you scan, you cannot keep turning the transducer in your hand freely. You cannot scan like that. You have to find the groove of the transducer, stick your thumb on it, and never let it leave that, so you know how you're scanning. That's the only way you can keep your orientation correct. I cannot overemphasize that, because if you don't keep your orientation correctly, you're going to miss cases like this. So if your sonographer comes in and says, wait a minute, why don't you check this, because I have checked all my orientation and I think something's wrong here. So obviously the lower uterine segment, the cervix, has the head presenting. But yet, okay, the spine is here. This should be the right side of the baby because the head is down. Why is the heart pointing down? So you go down to the abdomen, wait a minute, the stomach is down. This should be the right side and that should be the left. So you keep checking yourself, and this baby has complete situs, inversus. So it may not be very common, but these are the things that you could very easily miss if you don't keep reorienting yourself. Step 2, always look at the fluid. These are things that you have to do before you get focused on the fetus, because once you get started in the fetus, you're going to forget all these things. There are 2 ways that you can look at fluid. Dr. Leopold, who was one of our pioneers in ultrasound, said the best criterion for looking at the amniotic fluid is the YB software. And so everybody started writing down YB software and figuring out where they can buy it. YB stands for your brain. Look at the fluid, eyeball it, and see what it is compatible with, knowing that the relative volumes of fluid and fetus around 20 to 24 weeks equalize. Notice that I say relative because we know that as the pregnancy progresses, the absolute volumes about the fetus and the fluid increase. But this is like a proportion. How much baby is there in the picture versus how much fluid is there in the picture? At about 20 to 24 weeks, they're about equal. However, for people who have not been doing obstetric ultrasound for a while, this is a little difficult thing to get used to, because then you don't have any past experience to pull and say, okay, I've seen enough 20-weekers, I know that that fluid's adequate, or I've seen enough 30-weekers, that's a little too much fluid for a 30-weeker. So somebody came up with the amniotic fluid index, which the obstetricians like because it's an attempt to quantify how much fluid there is. And so what we do is we take the deepest pocket of fluid in 4 quadrants, and we add them all up. And it comes up with an amniotic fluid index number. Of course, every time the baby kicks or flips, this number changes. But this is a relative measurement given the variability of position of the fetus. But here's your eyeball criteria. Right about 20 to 24 weeks, there's about as much fluid as there will be fetus if you scan this whole uterus up and down. So most of the time, these 2 criteria are in sync with one another. If there is some kind of discrepancy where, subjectively speaking, it looks too much, but the amniotic fluid index is normal, then you have to do a follow-up to see if you can reconcile these 2 measurements. So you don't even have to determine the amniotic fluid index on this one. For a 2nd trimester gestation, this looks like a lot less fluid than you'd expect, and obviously there's something wrong with this baby because the chest is full of fluid here and the skin is thick, so there is something wrong, and that's reflected by the oligohydramnios. Here, there's too much room here, especially if this baby's in the 3rd trimester, because this baby has too much space between the anterior abdominal wall of the baby and the uterine wall over here. This is like looking at the fish in a fishbowl. Baby has so much room to move. The arms and the legs are flailing all over the place, and you know there's too much room. So you could measure the fluid, but just eyeballing it, you know that there's something wrong. 3rd step, look at the placenta. Not just for position, because here it's predominantly anterior, but also note that there's usually a nice hypoechoic myometrium behind the placenta. In women who had cesarean sections that are prone to developing placenta accreta, you will lose that lucency. And this is a very important finding to report, because that is probably your first clue that the placenta has grown into the myometrium. But sometimes when it has organized a little bit, then it will be a little easier to tell. So this is time to exercise your arms. Which of these two images represent a placenta previa? How many of you think it's A? Raise your hand. How many of you think it's B? Okay, a lot of you are undecided. If you are not sure where this placenta terminates, it's always good to do either a transperineal or an endovaginal examination to see where the internal os is relative to the placenta. Definitely this is a previa, partial previa, because it partially covers the os even if it hasn't completely gone around it. Here, this is what we call a pseudo-previa. This is what happens when your urinary bladder is too full to where your internal os is inaccurately depicted to be here, when in fact it's much lower than that once you empty the bladder a little bit. So this is a caveat. If the bladder is too full, see if you can get the mother to partially empty her bladder. It's better, it's easier said than done, because once she goes, she goes. But you can see how the position of the placenta relative to the internal os is changed once the bladder is a little bit emptied. So this is something that you have to remember. Again, placental abruption, when the blood has more or less organized to become less echogenic in comparison to the placenta, then you can probably tell that there was a retroplacental hemorrhage here, but earlier on it could be very difficult to tell. And eventually, hopefully, it will resolve and will not progress. Step 4, these are the routine measurements that anyone doing obstetric ultrasounds around the world does. Now, the estimated fetal weight is already programmed in your computer, so you don't even have to figure that one out. A lot of people feel that maybe the BPD should no longer be used, but it's our oldest and best known measurement, so we keep it and compare it with the head circumference. Now, if you're going to make these measurements, there are rules that have to be followed, because the charts that you're using were made on the premise that you are measuring it at exactly the same spot or the same level that the people who published those charts did those measurements. So the rules say that for the head measurement, you should have a fairly ellipsoid or oblong head measurement at the level of the thalamus, with the third ventricle in here. This is the cavum septum pellucidum. And there should be no cerebellum in that shot. And the fox should be interrupted, because if you go too high and the fox is continuous, you're too high in that measurement. Now, biparietal diameter is measured from leading edge to leading edge, or if you don't have a clear leading edge, you can go from the outer rim to the inner rim and get that as your biparietal measurement. And then when you measure the head circumference, you include the scalp around it. So these two measurements should be very close to one another in a normal cephalic head. Now, if there's some dolichocephaly or brachycephaly, then you probably should take your head circumference measurement over your biparietal diameter for accuracy. What about the abdomen? You should measure the abdomen after the umbilical vein has entered the abdomen. You cannot measure it at the insertion because you'll be too low. You're trying to measure the belly where it's biggest, and so you want to measure it after it has entered the abdomen and on its way to the liver. At that level, you will see the stomach, which you should always see after 16 weeks, menstrual weeks. And if you notice, 2/3 of that picture is made up of liver. The spleen behind the stomach is a small organ. So therefore, the abdominal circumference is really a good index of intrauterine growth restriction, because in malnourished fetuses, the liver shrinks theoretically, and therefore that abdominal circumference measurement becomes smaller and is the first measurement to go, or to lag behind compared to the estimated gestational age. The fourth measurement is the femur length. This is the ossified part of the femur. There's a lot of cartilaginous femur here that you're not measuring, but all the graphs were generated using the ossified part of the femur, so that's really what you're measuring. Just make sure that you do not include the interface at the cartilaginous part of the femur and stop right where the ossified part ends right there, so you don't erroneously lengthen the femur. So after you do that, you got to decide, okay, this is the average gestational age by the measurement. Where do I compare that? So question is, what is the most reliable estimate of gestational age? Those of you who think it's the BPD, raise your hands. Head circumference, abdominal circumference, femur length. How about crown rump length? Great. You heard Dr. Woodward. So here's the game. When you say this baby is 22 or 25 weeks, you're assuming that that baby is in the 50th percentile of these curves. So this is the name of the game. You're assuming that that baby is in the 50th percentile, and yet you know that people with the same birthdays don't have the same measurements. So that is why we have 2 standard deviations on either side of the mean, because we have to give leeways for variation in development. So you use whatever your best gestational age estimate is. If you have a crown rump length, perfect. Use that. If you don't have that, then you probably go to the best recall of the last menstrual period if the patient has a good recall. If not, you just have to get the earliest ultrasound you can get and use that as a comparison. But you have to have a comparison to judge whether the measurements you're getting now are appropriate or not. But if you have none of that, then you have to say, well, if your baby is perfectly average, it is 25 weeks old. Just remember that that's what you mean when you do that. Step 5, what about the head? Everybody starts smiling when I say make sure there's a head or there's a brain, because this is how anencephalics are missed. No matter how engaged the head is in the pelvis, there should always be a separation between the anterior uterine wall or the placenta from the fetal nose or face. So here's a normal head. Here are 2 anencephalic fetuses, one in the 2nd and one in the 3rd trimester. And these fetuses can present at term. If the woman has never had a prior prenatal exam, you will not know any anencephalics until they present at term sometimes. And usually the woman's abdomen measures larger than the dates that's expected. This could have been diagnosed before the end of the 1st trimester if this woman had an early ultrasound, but these can present at term on someone with no prenatal exam. And the unfortunate part is that everything below the orbits are normal. It's just there is no brain above the orbits. And so we go into, okay, what is anencephaly versus acrania? Anencephalics are usually those where you have nothing above the orbits. But sometimes you will see this very amorphous, abnormal looking tissue that is not normal brain, and yet there's no cranium around it. And now people feel that this is probably a spectrum, like eventually this is going to look just like this. But at the stage where you can catch it sometimes when that abnormal vascular tissue is still there, that's what most people would call acrania. Now, when you have determined that the brain looks normal, you have to document 3 things in the brain. You could take 1,000 images of the fetal brain, considering the many number of ways, the infinite angles you can get. But if you document 3 things, Dr. Philly has stated this since the early 80s. If you can only see 3 structures and document it every time, you would have ruled out the vast majority of the major intracranial anomalies. And what are they? The atrium of the ventricle, that should not measure more than 10 millimeters diameter transversely. See the cavum septum pellucidum and the cisterna magna. So even if you don't have a very cooperative fetus to image sometimes, if you could just get these 3 pictures, you would have taken the basic minimum structures to document. So how do you find these? In the early days, we used to have a lot of referrals for hydrocephalus because everybody mistakes the hypoechoic brain as ventricles. Now we know better. We know that the edge of the brain is here. That's not the ventricle. The ventricles are here. These are the 2 lines, the occipital horns. Right behind where the choroid plexus is where you measure the transverse diameter, like this one. Once the medial edge of the choroid plexus separates from the medial wall of the lateral ventricle, then you know this is a little loose. So even if that's within 10 millimeters measurement, you probably need to follow these up to see if this progresses into a frank ventriculomegaly. But normally, that choroid plexus should be snug. within the atrium of that ventricle. Secondly, the cavum septi pellucidum. I used to say cavum septum pellucidum when I was told that was wrong. You have to say cavum septi pellucidum or cavum of the septum pellucidum. So it should just be there. We don't have any good measurements for that. It could look like a square, a triangle, a rectangle. It should just be there. Every fetus should have one. This is your assurance that the brain has completed its separation into right and left. So the very subtle lobar holoprosencephalus or semi-lobar holoprosencephalus will probably get picked up if you just religiously pay attention to finding that. The third structure is the cisterna magna. It's always this fluid behind the cerebellum. Sometimes you can see some arachnoid slips into there. That's normal. But you should always see the fluid collection behind the cerebellum. This is the vermis right in the center. So in abnormalities where the vermis is hypoplastic or agenetic, this is going to measure deeper than 10 millimeters. So these are a lot of numbers to remember, but they serve a purpose. This gives you clues as to whether or not that brain has attained its maximum level of development. And if any of these measurements or any of these structures are not seen, then you need to refer to someone who probably has more experience than you, or suggest that a follow-up be done within the next few weeks. This is where we now start introducing terms like the lemon sign and the banana sign. The lemon sign is the concavity or the indentation of the frontal bone in fetuses with KRA2 malformations. The theory is when you have a meningomalocele somewhere downstream, it's just like sticking a pin in a balloon and letting some of the air out, and the frontal bones being the most malleable of the cranium, will sort of indent and show you the lemon sign. Now, when the skull gets to the point where it's no longer as malleable, like in 30, 32, 33 weeks gestation, it will resist that kind of caving in, so you may not see the lemon sign late in the 3rd trimester. But in the 2nd trimester, it's a reliable sign. More reliable is the banana sign, which is the hot dog-shaped cerebellum being wrapped around the midbrain. This is the cerebral peduncles here, cerebellum. And this is not always easy to demonstrate. But more importantly, you miss the cisterna magna. That means that your posterior fossa is so small that you plaster that cerebellum against the back of that skull to where you lose your cisterna magna. So all of these things need to be documented because these are all important clues that something else is going on. Now, while you're there, you might as well measure the nuchal skin, which is a very reliable sign for Down syndrome, and it may not be a requirement at this point in any of the accreditation guidelines, but it's so close. It's right there. Your cisterna magna is here. You might as well measure the nuchal skin from the outer skin to the outer skull over here, and anything above 5 millimeters is abnormal. Sometimes cephaloceles manifest at that level, so it's always good to demonstrate the gap in the cranium here and the brain or meninges that may be out. And we are all aware that once the brain is out, you can't just shove it in like you could a bowel in an anterior abdominal wall defect. What's out is out, so the prognosis is directly dependent upon the amount of brain that is out. So again, time to exercise your arms. Which of these is hydrocephaly? How many say it's A? How many say it's B? How many say it's C? Okay. How about holoprosencephaly? A? B? Good. C? Okay. And hydranencephaly? A? B? C? Great. These are very easy to confuse, so it's always nice to remember. And usually you'd have an obstetrician breathing behind your neck or a neurosurgeon that says, okay, do I shunt or do I not shunt when this baby is delivered? The key is finding this rim. This rim tells you that there is brain up in the convexities, because here now is the fox, so you're way up high. There's a rim of brain in the convexities, so this is a large ventricle. Maybe hydrocephaly is not always the proper term because you don't know that there's increased intracranial pressure there. The more politically correct term is ventriculomegaly. So if you're not sure if it's because of increased intracranial pressure, it's probably best to say ventriculomegaly. But here in a hydranencephalic, there is zero brain up in the convexities because the brain that is purely supplied by the internal carotid, which is the parietal lobe, is not there. Either it was there and got infarcted or it never developed. But this is the key. You have to get your image at the high convexities to make this distinction. Holoprosencephaly, obviously, if it's alobar, is easier to diagnose than it is lobar, because sometimes the degree of separation is a spectrum, but there's no fox here. There's a monoventricle, and the thalamus kind of looks a little globby. So all of these terms and all of these findings can be discerned if you take those 3 levels of measurement. Sometimes in the holoprosencephalic, where there's no fox, you can see some proboscis coming out from the front of the face, because these are the babies that we say where the face predicts the brain. And again, there's a mantle of brain around here, but just no fox and a continuous ventricle. Now we get into the issue of choroid plexus cysts, where you're looking at the atrium. Sometimes you will see choroid plexus cysts that look very complicated. Sometimes they could just look like small cysts. There's a variation in what kind of weight you want to give to this. At my institution, our obstetricians feel that if this is the only finding and the rest of the baby looks fine, this will not trigger an amniocentesis. But this, on top of 2 other findings, for instance, that will make him think chromosomal anomalies, especially tri-18, that would push them into doing the amniocentesis. So again, depending on the level of your comfort of your obstetrician, this may be an indication for amniocentesis. But the association is with tri-18 rather than Down syndrome. When you see a cystic area in the brain, always turn your Doppler on. You never know when you're going to encounter a vein of Galen aneurysm. Now, this is not a requirement, but just think. You tell the mother your baby's perfectly normal, and then the baby comes out with all kinds of clefts. That's not lethal, but it's just as catastrophic to the parents because you did not look at the lips. This is not hard to do. You just move your transducer in a coronal plane and slowly march forward until all you see is the tip of the nose, and you can see the upper lip, the lower lip, and the tongue in between them. This is a midline cleft, which has a lot more chromosomal implications than, say, a unilateral cleft or a bilateral cleft. And sometimes when you're not sure, you can use your 3D to demonstrate the cleft. Sometimes parents will accept this finding a lot easier if they can see it on the screen. And there are, of course, you have to choose the parents that can handle it and those that can't. But this is a very powerful picture when you show this to them. This is a baby that not only has a cleft lip and palate, but also has an ophthalmia on that side. So this is a chromosomal problem. Here's a tri-18 that has bilateral clefts and a lot of problems with the face on top of that. So 3D has a very powerful picture sometimes when you need to show the whole face. What about the spine? The accreditation bodies require that you show not just the cervical, the thoracic, but also the lumbar and the sacral. Now, they don't say that you should show longitudinal or transverse, but here's the transverse view. The skin is always intact, and there are 3 ossification centers that are clustered together. So which of these 2 views do you think is more important? How many of you say longitudinal? How many of you say transverse? Good. With longitudinal, you are seeing beautiful 2 rows of bones, but it could really be this one and that one together, or this one and that one together, or this and this together. You could miss subtle spina bifida if you only see 2 ossification centers. So even if this is adequate for now for documentation, you really should run the spine in a transverse view to make sure that you're not missing a subtle splaying of the posterior elements. Now, there's no problem if the meningomyocele is that big, and you can see the neural elements coming out, but if it's this small, it could be tough. All you see is the failure of the spine to taper towards the coccyx. This is the first case that made a believer out of me for the lemons and the bananas, because we saw the signs in the head, but we could not find this meningomalocele. We had to take her back a couple of weeks later just to see this spine again, because the first time around, this baby's butt was right up against the uterine wall, and we couldn't see this at all. So if you see lemons and bananas in the brain but cannot find a meningomalocele, look again. Chances are you're just not seeing it. Step 7 is the chest. Right now, the only requirement is the 4-chamber view, but there's more and more clamor to show the outflow tracts, because you'd be surprised how many major vascular abnormalities you can miss because you just look at the 4-chamber view. The 4-chamber view is perfectly proportionate sometimes, and yet you will have some major problems with the vessels, as I'll show you in a minute. So this is the right side. You can see the moderator band is very prominent, and you don't have to measure them. You can just eyeball them and say, that looks pretty proportionate. Here's the interatrial septum, the foramen ovale, and if you watch this on real time, there's always a foramen ovale flap that goes to the left every time. That's one way you can tell that that is the left atrium. And also, if you draw a line, usually the axis of the heart compared to the anteroposterior axis should not be more than 45 to 50 degrees. So there's a lot of clues in here to tell you that something may be wrong. And of course, you got to get a heart rate. Every baby should have a heart rate. So just by looking at a 4-chamber view of the heart, what are the things that you could diagnose? A large VSD. Obviously, little VSDs can still be missed. The echogenic intracardiac focus is a soft finding for Down syndrome. It's one of those markers that you have to pair up with other markers to give you a higher degree of accuracy. But it refers to this immature papillary muscle that looks like a bright area over here, usually in the left ventricle. And they all eventually disappear towards the 3rd trimester, so you keep following these up and they will disappear, because most people feel that this is just an immature or fibrotic portion of the papillary muscle, and it moves with the valve as they open and close. The best you can do with a 4-chamber, you still just see a small left side, small left ventricle, small left atrium. You know that that's a hypoplastic left heart. And here, you have an endocardial cushion defect in a baby with Down syndrome. These two valves on real time don't ever touch each other. So there's free regurgitation across here. And this baby will eventually develop cardiac failure, high drops, and die because there's nothing you can do about making these valves competent. Now here's the base view, where if you don't do the outflow tracts, you will not see this overriding aorta and the tetralogy of Fallot. Will not see that the pulmonary artery and the aorta are parallel rather than crossing each other, and both arising from the right ventricle. Just one vessel in the center of the heart in a truncus. And here, this is a baby encephalic presentation. Again, this is where your orientation helps, because the spine is here, the baby's head is down. This should be the left side. Why is the pulmonary artery coming from the left? And if the septum is intact, the pulmonary artery coming from the left and the aorta coming from the right should tell you there's a transposition of the great vessels. But that only comes because you are sure this is the left side and that is the right side. Now we now have fancy things. We can do 3D volumetric imaging. You can always get a perfect septum if you manipulate the data when you have the capability. But turning on your collar to see if you can find a tiny jet in a small VSD sometimes helps. So this is another dimension that ultrasound can provide. Now you go to the chest. After you look at the heart, you got to check the lungs and whatever else can be around there. So these are things that you could potentially see in the chest. If you got severe high drops with a lot of pleural effusion, there may be a little bit of fluid around the heart that could be normal, but pleural effusion is always abnormal. And if it's coupled with massive ascites and thick skin, then you know that you got a more generalized hydropic baby that you need to look for a reason for. CCAMs, type 1, type 3. Some of these disappear as the baby gets older, so it's always good to follow these up, because there's a lot of documented cases in the literature where originally a CCAM would not be detectable by the time the baby reaches the 3rd trimester. Pulmonary sequestration could look just like a mass. Here's the heart, here's the lung that's collapsed, a lot of pleural effusion, and that's a extralobar pulmonary sequestration, which is the most common type that you find. These are two very old cases, but I've never seen rhabdomyomas again after I've seen it in this baby. These are multiple everywhere. Baby with tuberous sclerosis. Now, step 8 is the stomach. Like I said, after 16 menstrual weeks, you should find a stomach. You cannot find a stomach, you got to look for a reason. This one has polyhydramnios, but there's a lot of reasons why the stomach may not be there. Maybe you just happen to catch it right after it emptied. It empties every 45 to 60 minutes. So you got to wait a little bit and see if it fills up. But most of the time, it's because either there's severe oligohydramnios and there's not enough fluid for the baby to swallow, or maybe it has swallowing disorders, either musculoskeletal in origin, CNS, because there's a facial cleft, or maybe because it's in the wrong place, or maybe there's an obstruction to swallowing. There's a lot of reasons. If you just think about all of these possibilities, then you can look for the view that could best detect these things. Sometimes you could have a TE fistula will allow you a little bit of fluid in the stomach, but after you've seen enough third trimester gestations, you know that that's much too little for a third trimester gestation, especially if that's the most it will get. So you start wondering whether there's something wrong. If you suspect this at all, you got to warn the obstetrician, who will tell the pediatrician not to feed this baby until this diagnosis is confirmed or ruled out. Here they have to decide how much the atretic esophagus is, so they can decide what kind of surgery to do. So they filled up the esophagus with some air contrast material, and so the stomach, and you can tell there's a very little web that connects these two esophagus. And here you could tell that it dilates and then tapers to nothing. So there's a lot of clues here to support the esophageal atresia. Diaphragmatic hernias, you got to be careful. Sometimes this view, even if it's classic, could be made to look like this if you're not scanning in the right angle. But in a true diaphragmatic hernia, usually the left side, the back of the leg hernias, you could have the heart pushed way over to the right side. It's dextropost, but the axis is correct. You got the left chest full of bowel, and you have to confirm that with either a coronal or a sagittal view where you can show the diaphragm and the stomach and the heart at exactly the same level. Now, these are, again, two classic images: diaphragmatic hernia, heart over here, stomach, bowel, diaphragm over here, stomach, heart. So there's no doubt about the diagnosis because you confirm this on two views. But here's a normal baby. First picture, man, looks like there's a diaphragmatic hernia here. But you just change your orientation a little bit, you can see that really there is no bowel where the heart is, and there's no heart where the stomach is. So you have to make sure that when you do actual images that you're really at a good orientation relative to the spine. What about the so-called double bubble? The double bubble sign has many causes, and the one that we know the most is duodenal atresia, because that's where the sign started in the first place. But all these other things are possible to simulate the double bubble sign. So here's a baby with a classic double bubble on a plain film. And if you watch these two fluid collections, the bigger collection is the stomach, the smaller collection is the duodenum. In a true duodenal atresia, there's no other places fluid can go, so you can see it go back and forth between these two collections. It doesn't go any further, it just goes back and forth. It's pretty fascinating to watch. But if it's just a stenosis rather than an atresia, then sometimes you could pick up some fluid distally. Step 9, we have to see the cord insertion. You cannot find it, bring this patient back. There's so much you can miss if you do not document the cord insertion. While you're there, you can count the number of vessels in the cord, because that's another requirement in the accreditation package. And you always have to look for the more common abdominal wall defects, gastroschisis, omphalocele. You can look through all the literature about the different ways they manifest, but the key finding is the cord insertion. You have to see where the cord inserts into the abdomen, because your diagnosis depends a lot on where it is. So, here's a gastroschisis. The cord inserts normally, The defect is usually to the right, and even if it's a tiny defect, look at how much bowel can get through that defect. Here's a side view of that. And when the bowel gets dilated and starts to have thick walls, you kind of worry whether there's ischemia going on, maybe there's bowel rupture that's impending. You cannot deliver this baby early. The surgeon needs a good-sized baby to operate as soon as it's born. So our surgeons, no matter how bad the bowel looks, will tell us not to hurry delivering because they want a good surgical risk infant to operate on. And if some of the bowel becomes ischemic and infarcted, they just have to cut the ischemic or infarcted part and try to connect the good bowel together. But you cannot deliver a premature baby and risk pulmonary immaturity and have a bad outcome. If you need to use your Doppler, go ahead and do it because you need to show where the cord insertion is. Again, to the right of the cord insertion is the classic gastroschisis defect. And if you don't see the cord insertion at all, and all you see is bowel floating everywhere, your diagnosis of gastroschisis is probably more correct than not because this is classic for gastroschisis. Bowel is out, and if it is liver, then chances are it's an omphalocele. In omphalocele, you cannot see the cord insert normally into the abdomen because it always inserts at the apex of the defect. The vast majority of them will have liver in it, although bowel-containing omphalocele have been reported by Dr. Nyberg and his group to have more association with chromosomal anomalies. But always the discriminatory finding is the insertion of the cord at the apex of the defect. And of course you have a membrane that has both peritoneum and amnion in it, so you can see that the membrane covers the classic presentation of an omphalocele. We call it a giant omphalocele if it's 5 centimeters or more. And here you have to define for the surgeon what happens to the aorta and the vena cava because that would help him decide how complicated the surgery is going to be. So again, no matter how big the omphalocele gets, the cord still inserts at the apex of the defect. So this is a good summary of the differentiating point. If all you see is bowel, chances are it's gastroschisis because omphalocele usually contain liver. Always look for the cord insertion to see where the defect is and where the cord inserts. And there's a special kind of omphalocele called pentalogy of Contral. These are the big, high-riding omphalocele. There's an associated ectopia cordis. So if you look at the ectopia cordis and the giant omphalocele in the middle, those are two components of the pentalogy. The other three is what happens in between those two to make this abnormality happen. So you got the sternal defect, pericardial defect, diaphragmatic defect, because then, and then cardiac anomalies, because then that is how this whole syndrome or finding or classic presentation manifests. And usually you will see other abnormalities. Here's a 2-vessel cord in this baby. So Dr. Woodward told you that if you see bands, that usually tells you that there's been a disruption in the amnion-chorion integrity. Bands are bad past 17, 18 weeks. Usually you expect the chorion and the amnion to fuse, definitely by 20 menstrual weeks. So any lines that you see floating in the amniotic fluid beyond 20 weeks has got to raise some red flags. Bands can be found in amniotic band syndrome, limb-body wall complex, all kind of complicated abdominal wall anomalies. So here are multiple amniotic bands floating. And you couldn't even tell where the normal abdomen is in this baby because everything is out. The bowel, the liver, everything. And once you have orthopedic problems on top of the amniotic bands in the severe opening in the anterior abdominal wall, you got to think of the limb-body wall complex. Again, this is not very common, but this is how your thinking should follow. Cannot find the cord insertion. Got bowel, liver, orthopedic problems. Look at the spine. The spine is very abnormal. You got clubbed feet, claw hands, all kinds of anomalies that you cannot explain just by amniotic bands alone. So you have to theorize that way back when the body stalk was developing, some vascular insult occurred that led to this very complicated problem. And no matter where you, a lot of limb-body wall complexes always have orthopedic complications. Here's a foot Here's a foot and the spine on top of the massive herniation of viscera into the anterior abdominal wall. Okay, we're getting close. Step 10, what about kidneys? Beautiful kidneys. Okay, we measured the renal pelvis and the anterior posterior diameter of the kidneys. And anything above 4 millimeters as far as dilation of the renal pelvis is suspect. If it's symmetric and bilateral, sometimes we can say, oh, that could just be reflux because the UV junction is immature. So maybe that's just what it is. But if it's more than 4 millimeters, you're obligated to at least follow it and make sure it doesn't get any worse. Big kidneys occupy more than a third of the corresponding abdominal measurement, whether it is a diameter or a circumference. So you can't call kidneys big until they get to that point. What about if there are no kidneys? Bilateral renal agenesis is a real bad diagnosis to make, and a diagnosis that most people are afraid to make because then it implies that this baby is not going to make it. But look at what happened to the adrenals when there are no kidneys. They occupy where the kidneys are. They look like kidneys. And you don't see fluid in the bladder because there are no functioning kidneys. And from case to case, it's always the same finding. Big organs in the paraspinal area that look like kidneys but are not kidneys. Zero fluid around it and no urinary bladder. And when the babies are born, you can see huge adrenals, no kidneys, just huge adrenals. So the question is, how can you tell between kidneys and adrenals? How many think it's because they're paraspinal? How many think it's because of the pyramids or the absence of pyramids? 1. Echogenic central complex, is that helpful? No? How about their ovoid shape? Now, if you remember, the kidneys have these beautiful pyramids that the adrenals do not have. They're arranged in a nice concentric arrangement around a very minimally dilated renal sinus. Adrenals don't have pyramids. Only kidneys have pyramids. So that would be something that you should look for if you want to make the distinction. But obviously, if there's zero fluid around the baby, you have to start thinking there are no functioning kidneys. Bilateral hydronephrosis, like I said, if they are symmetric, you can keep checking and hopefully they will resolve. We probably do one follow-up late in the 3rd trimester, and if it hasn't become worse and the fluid remains normal, we will just suggest a neonatal follow-up. What if it's asymmetric? You got to start worrying about UPJ obstruction. Here's a normal kidney with very minimal distension of the renal sinus here. And when they're huge, they could obstruct the other side. This one still looks pretty normal. But this huge renal pelvis could obstruct the other side and compromise the other kidney. So again, this needs a follow-up, if only to make sure that the other kidney remains normal. And when the babies are born, they don't look any different. Normal kidney on one side, huge bag of water on the other side, huge renal pelvis. Multicystic renal dysplasia, we were told a long time ago that they're typically unilateral, but now we're finding more and more bilateral multicystic renal dysplasias. They're bizarre looking. They don't look like kidneys at all. They have cysts of varying sizes. The other kidney looks perfectly fine, but this one is growing to where it's crossing the midline and occupying more space. So again, you got to watch, make sure the other kidney remains normal. Autosomal recessive polycystic kidney disease are very typical in the sense that they maintain their reniform shape. They're echogenic. Sometimes you will find some macrocysts, but they fill up almost the whole belly. Like here's the whole belly, and the kidneys go all the way up to here, both sides. And sometimes when you got multicystic renal dysplasia associated with a cephalocele, then that's what constitutes the Meckel-Gruber syndrome. Occasionally you will see a horseshoe kidney in utero. Not very common, but looks just like what you see in adults. How about the urinary bladder? Our sonographers love to get this picture because it's easier to document 2 umbilical arteries this way than having to catch a cord in cross-section somewhere. So they see the urinary bladder, they turn their Doppler on and document their 2 umbilical arteries. But just like the stomach, the bladder should be there any time after 16 weeks. You can't find it, you got to explain it. Sometimes they give you a beautiful keyhole configuration, as in posterior urethral valves in a male baby with associated severe hydronephrosis. And the last step in a fetal evaluation is documenting extremities. You don't need to count toes or fingers. You just have to document there are 4 extremities. And if you see persistently clenched fists, try to bounce those hands. See if you can make them open. Persistently clenched fists are not good. Or you got clubbed feet, try to move the foot away from the maternal uterine wall, because sometimes if you got a baby that has just kind of like pushed to the side of the uterus, it could give you some crowding clubbed feet or pseudo clubbed feet. But when they're real, they're going to stay in that orientation the whole time. Now, when you don't understand what's going on with an extremity, again, 3D can come to your rescue. You can see where the heel is up here. Here's the forefoot. And here's the ankle. So it just confirms this 2D image of what may look like talipes deformity. What about, this is so catastrophic. You tell the mother your baby looks fine and it comes out with no arm on one side or no leg on one side. It's happened before, so I guess that is why documentation of 4 extremities has become a requirement, because this is, again, even if they're not lethal, they're catastrophic. So here's the normal hand and forearm, and this is all the arm that you can see on 3D on the other side. And did an MRI, the same little nubbin that you see with the normal hand on the other side. So it helps to verify these very dramatic findings with an MRI if you need to. Now, I am becoming a believer in cine clips. I'm getting into where I would rather do more clips and less statics than do a lot of statics. Because there are no words to describe the findings in, say, osteogenesis imperfecta type 2, where you can see the fractures and the severe shortening of the limbs in this fetus that was born with classic findings. Now, how do you make this diagnosis? Here's a normal baby. The ossification of the spine and the skull are the same. You can see artifacts arising from the near field like you're used to. And the ribs are usually nice and curved. In osteogenesis imperfecta, your skull is severely hypomineralized compared to the spine. You should always get this picture. I don't care how good your machine is, you don't get brain this good. And there's severe micromelia, like this lady's supposed to be 20 weeks pregnant. This femur is only 13 weeks max. And look at our curve, the ribs are broken and pointed out. When you see this constellation of findings, and you can make this diagnosis in utero. The other types of osteogenesis imperfecta are more variable, but this type you can make the diagnosis of. Now, for completeness sake, you can look. We don't usually tell the mothers this unless it's important in the diagnosis, because you'll have mothers come in at 3 o'clock in the morning pretending to have some symptoms just to know if it's a boy or a girl. So we try to discourage that in the middle of the night, but we don't make this as a routine part of our report. So now we have gone from 2D to 3D, and this is my granddaughter. When my daughter-in-law felt no movement for a couple of days, and we all got worried that something's wrong. We brought her in for a biophysical profile and did the 4D. Now, 3D plus motion is 4D, and we still haven't found a lot of applications for this, but you have to agree that this is very reassuring to both the mother and the obstetrician to see that this baby is really very active and not what they're suspecting is wrong. But this was when she was born on the first day, and she looked exactly like that 3D image that we saw in utero. So in conclusion, to do a comprehensive examination at least once in pregnancy, you should have a systematic, consistent protocol that you follow from month to month to month, and try to use as much cine and 3D imaging if possible. And you should always document these images not just for accreditation, but because it's the right thing to do. So I hope I have convinced you that there are very simple 12 steps in doing that.